Uh, I will be performing sciatic nerve block. Okay. The anatomy has already been described. I will be just repeating the landmarks once again. For performing a sciatic nerve block, the patient's position should be like that, that the limb which has to be anesthetized should be on the upper side. So this is how the position is kept, and it should be a Sims position where the leg which has to be anesthetized rests on the other leg, so that we will be able to visualize the twitches very well. So this is how the position is. Now after that, I have marked the greater trochanter by palpating it from lower down. And the moment I end up with the bony landmass, that is the highest point of greater trochanter, and I have marked it here. So greater trochanter has been marked. A second point is at the PSS. The PSS can be identified by two things. One, you can trace the iliac crest lower down, or it is just a dimple on the back. So I have marked the PSS also. A line is drawn joining the greater trochanter to PSS. Okay. Now the width of this is taken. It is about 18 centimeters and the width of it is 9 centimeters. A line exactly perpendicular to this is drawn, which is 4 centimeters lower down. This is the point of insertion of the needle. This point can be reconfirmed by drawing a line from greater trochanter to the sacral hiatus. So this is the sacral hiatus and a greater trochanter. I will draw one more line from that. The point of insertion of the needle should be here. So the lines should cross this point of insertion. That reconfirms my position of the needle, or my position of insertion of the needle. As it is a lower limb block, the local anesthetic should be used in a large amount, nearly 4 to 5 ml, and the patient should be sedated well. So now I will be giving a local anesthetic. Now the direction of my needle is exactly perpendicular to all the planes. Two percent of xylocaine, 2% xylocaine is used for this. To perform this block, we need a little bit larger size of length of the needle. It is 10 centimeters long, an insulated needle, which is flushed first. It is attached to the nerve locator with a positive end to the patient and negative end to the exploring needle. Now, my needle is inserted exactly perpendicular to all the planes of the Now I am getting the twitches, small twitches. The patient is little bit obese, so I may take a little bit more time. Now I am getting plantar flexion. That indicates me that I have stimulated the tibial nerve. Can you see the plantar flexion?
It is in Ashit.
I will reduce the current slowly, and simultaneously I will be manipulating the needle. the patient is diabetic and old age, so I am expecting I will be accepting these twitches at 0.5 milliamperes, and this is the end point of this block. That's okay, I think. Now I am getting plantar flexion at 0.3 milliamperes, so that I will withdraw the needle little bit. Okay. थोड़ा सा करंट बढ़ोगे. Okay, I am getting plantar flexion at 0.4 milliamperes. At 0.3, this is the end point of my block. Can you appreciate the twitches?
It is very well seen.
Okay, now I am injecting the drug. After injecting about 1 ml of the drug, the twitches disappear. The immobilization of the needle at this point is very important. Dr. Sandeep is injecting the drug and he is not, there is no resistance while injecting the drug.
Ashit, you don't expect resistance when Sandeep is injecting, okay?
The required quantity of drug is about 20 to 25 ml.
Guru, I am helping him out, right?
Yeah, I know. Ashit, this case is posted for debridement of the toe or?
Yes, yes, he is posted for debridement of the second and third finger.
Are you going ahead with the femoral block or are you not?
No, now Sandeep will perform a sauce compartment block for this patient.
Just show the depth of the...
The depth of the needle was about 8 centimeters.
Okay. How much volume did you inject, Ashit?
I injected about 20 ml of the drug.
Okay.
0.5% bupivacaine.
Acha, only 0.5% bupivacaine. How long will the block, when will the block start to act?
It takes at least 20 to 25 minutes to act.
Your surgeons are cooperative there?
Yes, definitely. I performed the block 20 to 25 minutes prior.
What is the gauge of the needle used?
Gauge of the needle used?
It is 22 gauge and 100 ml, 100 mm.
Hello? Excuse me.
There is a question, Ashit.
Huh.
Sir, why we prefer to elicit this tibial response?
The tibial nerve and peroneal nerve, out of which the tibial nerve is larger in size, so it's always better to accept the twitches of the tibial nerve.
Can we give a rescue block if common peroneal nerve is spared at the level of neck of fibula?
We can give, but it is said that no drug should be given at the point where the nerve is at the point of the bony structures, because it may get compressed.
Right. Thank you.
If you get a tibial nerve, if you can able to cut the tibial nerve, then the block will be much more definite one.
Yeah.
That's a plantar flexion. Otherwise, it's a dorsiflexion and femoral, I mean peroneal. The tibial part is the more definite one. Is it? Is it? Okay, Sandeep.
Yes, I didn't get you.
No. The tibial compartment, if you get a plantar flexion and got the tibial nerve, then the block will be a more definitive one.
More definitive.
Than the getting the peroneal area.
Right. Thank you, Dr. Ashish.
Yeah.
We're
Now,
just shifting to the next room, sir.
Dr. Sandeep will be performing a sauce compartment block.
1 second. So that means you want to stay in this room?
Yeah.
Okay.
Yeah, can you hear me?
Yeah.
Yeah, these are all deep-seated blocks, the sciatic and the lumbar plexus. And the lumbar plexus is it would be more difficult because you have to go beyond the transverse process, and you have to sight the femoral nerve inside the psoas major muscle, or maybe just before it exits the psoas major muscle, and the end point will be quadriceps twitch. It could be a difficult block at times, and particularly in obese patients like this, it might take a bit more time, as Ashit correctly mentioned. Now, the anatomical landmark is what he has cited is posterior superior iliac spine, and there should be a line which moves cephalad from here up, and you palpate the iliac crest, and the line, the intercostal line, which passes in this fashion, it should intersect the line from the PSAS upwards. The point of insertion of the needle is the point of intersection of these two lines at this point. So this is quite away from the spinous process, maybe around 4 centimeters from this spinous process. So we is already be infiltrated. So we go through the skin and the subcute, and then you can cut off the nose stimulation. We'll do it later on. The ideal thing is to correctly feel for the transverse process. Once you feel for the transverse process, it is then that you go beyond the transverse process and 2 centimeters beyond the transverse process. So you try to hit the transverse process first, and that will give you the exact depth of the needle. So this is the transverse process that I have hit, and then I go 2 centimeters beyond the transverse process, and you move either cephalad or you can move caudate depending upon where you want to, and sometimes you can feel a click. Can you start the PNS? Yeah, 1 million pairs. Okay.
How deep did you get the transverse process?
This was 8 centimeters almost. 8 centimeters inside the from the skin.
Okay. No, only the upper, portion, the leg to be operated is on the upper side. So
Yeah.
only that is flexed.
Only that is flexed. Yeah, you can flex the lower this thing also. It doesn't matter, but usually the upper ring is flexed. The contraction is from the skin. It was 6 centimeters. It was not 8 centimeters.
Okay.
It was 6 centimeters. Okay.
Yeah, we can.
You can see some contractions there.
Yeah. Ask the camera to be placed
Yeah,
at the.
he should be from the front. Like 1 minute. We'll remove this. Okay. Can you see those contractions now?
Yeah, it can be seen.
Okay. See, now I have left the needle by itself. I am not manipulating the needle. That means it is very close to the femoral nerve inside the sheath. Okay. Now I am trying to reduce the current,
Okay.
and the current is going down to 0.6, going down to 0.5, going down to 0.4, and then it disappears. So if it is at 0.42, it's good enough to have those. You can see the vastus lateralis, you can see the quadriceps contractions, and if you would have made the leg straight, you could see the patellar, even the patellar dance. You can see the depth of the needle over here.
Okay. How much more have you gone inside?
Yes, see, this is 10 centimeters, so it's almost
7
centimeters. So
Okay.
it should be 1 to 1.5 centimeters beyond the transverse process.
So you
As
went
yes,
1 centimeter.
yeah, as we had discussed yesterday, the distance from the transverse process to the lumbar plexus is constant throughout. It's
Okay.
fixed. It's from 1.5 to 2, but the distance from the skin to the transverse process can vary,
Okay.
isn't it? So we now aspirate. and we inject the local anesthetic. Can you see those contractions?
It's still there.
It's still there. At times you might feel some resistance in the psoas muscle because see, you're giving an intramuscular block. Sometimes you can feel the resistance, but that resistance doesn't mean that you're in the nerve itself.
It disappeared now.
It disappeared now. And remember, the lower limb blocks are more difficult than the upper limb blocks.
Okay.
They are deeply situated, and the anatomy might vary even for the sciatic and even for the lumbar plexus.
Okay.
And that is the reason sometimes most of times you get more failures with the lower limb blocks. But that should not make you move away from the lower limb blocks.
I thought you were trying to defend yourself.
In what sense?
That the block will be partial.
Not at all. You will see tomorrow me and Ashit going to fight for that
Epidural and
epidural and lumbar plexus.
okay.
And this needle was directed cephalad initially. You could not get anything. So you remove it up to the level of the skin and the subcute. And then you again hit the transverse process, and then you go a bit caudally. But all the time the needle has to be parallel to the operating table and perpendicular to the skin.
Okay.
So he has given around 20 ml of local anesthetic, and I give around 20 ml of local anesthetic, so that it should take care of the lower limb, unilateral analgesia and anesthesia. But the duration will be more, like it will take around 20 minutes, even half an hour, as we had discussed yesterday.
Okay.
I'm removing the needle now, and in fact, if I would have placed an ultrasound probe here, you could see the needle hitting the transverse process and going beyond that, and you could see sometimes the root coming out of the below the transverse process and the pedicle, and then you can see the drug going into the psoas compartment, everything.
Okay.
We could have shown with ultrasound.
Any questions?
Dr. Sandeep, you want to show it with the ultrasound? No?
Yeah, we have that ultrasound here.
You want to show it?
We'll try to show it. No, you don't remove.
Hello.
Can I ask one question, please?
Yeah,
Sir,
please.
Sir,
Yeah, please.
That you said
sir,
that
since it is an intramuscular injection in the psoas muscle,
Yeah.
what about the dose of the local anesthetic vis-a-vis when you give it in this perivascular sheath?
No, I did not get you, sir.
Sir, when we give this block, you have told that it will go into the psoas muscle.
Yeah, into
that
the
means
psoas.
intramuscular.
Yeah.
Do you decrease the dose of local anesthetic?
No, it is the same. The dose is not reduced at all. At any point in all the blocks, the concentration and the volume will remain the same throughout. I did not understand why you should reduce the dose.
There must be, will not there be more absorption since it is in the intramuscular site?
I don't think so.
this question about the point of needle insertion, sir.
Yeah.
You said that the line from the PSS should go up
Yeah.
and it bisects it should bisect the intersect line.
Yeah.
But the line which is going from PSS, what angle it should go up? At what angle?
No, it should go straight.
Straight.
It should go straight.
Okay, okay.
Okay.
Sandeep, I'll answer him. Actually, that line which passes through the PSIS should be parallel to the line joining the spines. First you draw a line to all the spines, then you draw a line parallel to that which passes through the PSIS.
Sir, one question.
Guru,
Yeah,
I am trying to show the ultrasound. Are you getting it?
yeah.
Yeah. So can you see the needle jiggling over there?
Yeah.
See, it's now everything is still. From the right side where she is pointing out,
Okay.
can you see the needle jiggling?
Yeah, we can see some movement.
Yeah, you can see the movement. That is the needle which is going. It is hitting the transverse process and going beyond that.
Okay.
And I will try to inject a few volume of. That's fine. No. Can you see the? Can you see that?
Not clearly.
I am injecting in boluses. You may not be seeing on the screen. It's low down. See,
Can you get the cursor there?
down. Yeah.
Okay.
You may not appreciate there on the big screen, but here could see some volume.
Okay.
Removing the needle. I'll show you. Some water.
Sir, one question.
what water to drink.
Yeah.
Thank you, Dr. Sandeep.
Yeah, thanks.
Sir, one question.
One question is there.
Okay.
Sir,
Dr. Sandeep, we are still with you.
Yeah.
sir,
We have a
to rule
question,
out intraneural injection, you will be checking the twitch at 0.3 milliamperes,
Yes.
if it is there. But at which current level we should start giving means, for example, somebody is saying 1.5 milliampere is enough, somebody is saying 0.4 milliampere. Is there any hard and core rule below which we can rule out intraneural injection?
No, nowhere beyond 0.2 milliamperes.
Nowhere below point.
No way below 0.2 milliamperes, because the animal studies have confirmed that if you go below 0.2 milliamperes, it is very much intraneuronal. That's why it has to be at beyond 0.3 milliamperes. I think we have a case going on in the next OT.
Yes,
we can
sir.
discuss it later
Thank
on.
you, sir. Sorry, ma'am. We have